So, hello friends, good morning. So, I'll be talking on this very important subject, right ventricle in ICU, overlooked entity. So, this talk I gave in Kolkata Critical Care Congress on 8th October. So, it's a very important topic for intensivists because I'm sure most of the listeners would understand that having a grasp on understanding right ventricle is always a very challenging topic for an intensivist, and so would be, I would think, for cardiologists as well. So the topics I would cover are introduction, and it's important to appreciate as to what is the mechanism that is involved in causing RV dysfunction and what is the epidemiology. So what is the prevalence or the occurrence rate of this RV dysfunction in ICU, and the clinical presentation and diagnosis of RV dysfunction and RV failure in ICU. So it's very important to understand the treatment principles. I'm sure many of you would agree treating RV failure is the most challenging and possibly very difficult aspect with regards to assessing the volume responsiveness or be it inotropes and so on and so forth. So we'll talk about the overall principles. Then it's very important to understand the targeted management in specific scenarios. The reason is there is always an underlying etiology for RV dysfunction. And to a large extent, we need to address the underlying etiology. And in some cases, RV dysfunction may be complicating the other critical illness. And it's also important whilst dealing with other critical illness that we try to address this RV dysfunction. The typical case in example would be ARDS, because ARDS, it is shown that 30 to 40% of them will develop RV dysfunction. We'll talk about it and we'll talk about conclusions. So when you look at the main predominant causes of RV dysfunction, so the one which comes in the forefront is the acute pulmonary embolism. So we deal with this in ICU. So it is important to appreciate that pulmonary embolism becomes one of the leading cause of RV dysfunction and RV failure. And posterior wall MI. So this is predominantly dealt with by cardiologists, and many a times we also would see. So through posterior wall MI is possibly the second cause, commoner cause of RV dysfunction, RV failure, and the conundrum. And for intensivists, at the end of my talk, if intensivists appreciate that ARDS becomes an important cause of RV dysfunction, I would have done justice to the talk. So this is something that this talk possibly should emphasize, that patients with ARDS up to 40%, the severe ARDS, 40% of them will have concomitant RV dysfunction, possibly as an intensivist, including me. We may not really assess it in a way that we should be assessing in a very vigilant, diligent, and regimental way. So that is something if we can take home as a lesson, I think that would be good enough from this talk. So ARDS becomes an important entity which causes RV dysfunction, RV failure, and this may also possibly lead to delayed weaning from the ventilator. This is something I want every intensivist to appreciate. And the fourth important domain, which possibly cardiac surgeons and others deal with, is post-operative cardiac status. So this is any patient who's undergone cardiac surgery, so they are at a risk for RV dysfunction is something that one needs to understand. So these are the four commoner causes which we would try to cover in this talk. Or any other condition where there is alteration in the structure and the function of RV also can lead to RV dysfunction. But these are the four leading causes that one needs to keep in mind. So what is the definition of acute RV dysfunction? So I would use the word RVD, which is RV dysfunction. So the definition is where there is a systolic dysfunction of the right ventricle, where pictorially I'm showing you this is the right ventricle which is dilated, and there is a systolic displacement or enlargement of the right ventricle. So the right ventricle gets enlarged in the setting of systolic dysfunction, and where there may be an increase in the BNP, B-natriuretic peptide, or there is an ECG evidence of right ventricular strain. So as you see, there is R wave in the lead V1, and there is a strain pattern with T inversion. So if you see any of this, then one has to keep in mind there is possibly RV dysfunction setting in. And so that in essence, if you have any of these three things, RV dilatation, systolic dysfunction, which is assessed by your TAPC, an increase in the BNP, and RVH with strain, this constitutes RV dysfunction. So then what is acute cor pulmonale? Acute cor pulmonale is where there is signs indicating there is increase in the right ventricle afterload. That's when you say there is acute cor pulmonale or acute dilatation of the RV, which is increase in the afterload. And what is the definition of acute RV failure? So these are the three definitions that possibly one needs to keep in mind, and they can be used in a very interchangeable way. Acute RV failure is what possibly we see in ICU, where there is severe RV dysfunction with fall in the cardiac output, leading to hypoperfusion and multi-organ dysfunction. So you have RV dysfunction. Not all RV dysfunctions lead to drop in the cardiac output or hypoperfusion, but when it is leading to a hemodynamic compromise causing fall in the cardiac output, we call it as RV failures. And how would we assess RV failure? Obviously, you do TAPC. If TAPC is less than this talk is, there is a separate video which I've done on only RV function assessment. Here I won't cover too much, but if you have a TAPC less than 12, then obviously you know there is an RV failure. But more than TAPC, you can use these indices. And I was just mentioning and need to emphasize possibly RV failure or RV dysfunction is possibly a condition where an intensivist can rely on CVP. And possibly the role of CVP, we understand as intensive care crowd that CVP measurement has become obsolete. But in conditions where you want to assess RV failure, I would try to emphasize that CVP has a role because very high CVPs can be a guide for diuresing these patients. So this is a simple definition where your CVP or the right atrial pressure divided by pulmonary artery wedge pressure. Obviously, we don't put PA catheters to measure. You can look at LV filling pressure by echo. So right atrial pressure, which is CVP divided by left ventricular filling pressure would easily, if it is more than 0.8 to 1 with reduction in the cardiac index, that tantamounts to your RV failure. So it is very simple calculations which on bedside echo you can do. With a, if there is a CVC line, you transduce it, check the CVP, and you can do the LV filling pressure with echo with tissue Doppler index, and you see. So basically, it is intuitive, which tells if your RAP is if the ratio is more than 0.8 to 1 with fall in the cardiac output, it really tells you that there is RV failure. So, and what is the mechanism and how does this RV dysfunction sets in? So just remember this picture, which I'll show you. This will summarily give you a conceptual understanding of what happens in RV dysfunction. So in RV dysfunction, there can be an overload of pressure overload and volume overload. It can be either of them or both present. So when there is an overload, pressure overload and volume overload, it leads to reduction in the myocardial contractility of the RV. So there is reduced contractility. And when there is reduced contractility, we call it as systolic impairment of the RV. So when there is this reduced contractility with systolic impairment, then the tricuspid regurgitation sets in. Almost always RV dysfunction or RV failure is always associated with tricuspid regurgitation jet, TR Along with TR, once the TR jet sets in, then there is systolic impairment, RV dilates. There is dilatation of the RV. And together with this conundrum of systolic impairment, tricuspid regurgitation, and your RV dilatation, there is reduction in the RV stroke volume. That's when you say that cardiac output is come down of the RV. And every listener would understand that the RV and LV are interdependent. So there is interdependence because RV stroke volume has come down. So there is increase in the left ventricular end diastolic pressure and the cardiac output of the LV also comes down. So please understand when the RV stroke volume comes down, it has a direct bearing on the cardiac output of the LV because of reduction in the cardiac output due to increase in the left ventricular end diastolic pressure and the left ventricular stroke volume also comes down. So the RV stroke volume is interdependent on the LV. And always remember, there is interdependence of RV on the LV. And the acute right ventricular dilatation leads to increase in the right atrial pressure, increase in the CVP. And sometimes when there is a patent foramen ovale, which is present, there is a right to left shunting that happens. So this is the physiological and conceptual understanding of what really happens in RV dysfunction, which I've shown you in a schematic way. So for all the trainees, if you just keep this picture in your mind, it makes your understanding of the RV very easy. And this is exactly what happens physiologically when there is an RV dysfunction. So you can keep this picture in your mind for your exam. And even when in exam you're answering this, you put this in a pictorial way. I think it makes your understanding much easier. So this is another concept I want you to understand in RV because in ICU, the RV dysfunction very often we may see in a mechanically ventilated patients. And every intensive care trainee need to understand what is the effect of mechanical ventilation on RV because summarily the effect of mechanical ventilation on LV is favorable for hemodynamic, but on RV it may not be favorable because it reduces the preload and it increases the RV afterload. So if this is the inspiration, schematically, if I'm showing inspiration and this is an expiratory curve, so in mechanically ventilated patients, we know there is increase in the pleural pressure, and there is increase in the transpulmonary pressure. So with this, what happens is in mechanically ventilated patients during inspiration, there is reduction in the preload, and there is increase in the RV afterload. So this is something one needs to understand. In ventilated patients, puts more strain on the RV because there is increase in the afterload and reduction in the preload, because RV contractility is dependent on normal preload. Too much preload also is bad, less preload also is bad, and there is reduction in the stroke volume, which is naturally happening. So when there is an already present RV dysfunction, RV failure, your mechanical ventilation can accentuate your reduction in the RV stroke volume. And the opposite happens in the LV. In the LV, there is increase in the preload and reduction in the afterload. That's why ventilated patients is friendly to LV. LV afterload reduces, and there is increase in the stroke volume. In fact, in a patient where there is comes with pulmonary edema, when we mechanically ventilate, the afterload comes down, there may be improvement in the cardiac output. And this increase in the stroke volume during inspiration is measured with maximum pulse pressure, and during expiration, it drops down. And this change during inspiration and expiration is what we quantify in our ICU as pulse pressure variation, which we use it as volume responsiveness, because we look at this difference. If this difference of pulse pressure is more than 12%, we say that patient is volume responsive. But having said this pulse pressure variation or stroke volume variation may not be dependable in RV failure. Although we use this, it may be useful for LV or any other problems, but for RV, this becomes non-dependable because of the caveats that it will have. We'll talk about it. So I want you to understand this physiological rationale in ventilated patients on RV in relation to inspiration and expiration. So this is very important for trainees when we are discussing about volume responsiveness. Even this figure, if you keep it in mind, imprint in your mind, it is easier for you to conceptually understand this. So this is about the effect of ventilated patients on RV, which is not very friendly because it increases the afterload. So that's about the physiology aspect. So we'll talk about epidemiology. So these are the references that I put for the statistics. So pulmonary embolism, as I said, is possibly one of the leading cause of RV dysfunction or RV failure. And echo in hemodynamically stable, it is shown 30 to 56% of the time can recognize and identify RV dysfunction and RV failure, and it can recognize increase in the afterload. And the increase in the pulmonary artery pressure is something that happens in pulmonary embolism, which we understand. And this increase in the pulmonary artery pressure happens when 40% of pulmonary artery is obstructed. The 40% of the cross-sectional area of the pulmonary artery, if there is an obstruction, there is increase in the pulmonary artery. Until then, PAP does not go up. So that is something you can understand. And 30-day mortality in pulmonary embolism is around 5.4 to 10%. And hospital mortality is accounted as 1.1 to 3.3%. But when pulmonary embolism has shock, and pulmonary embolism leading to shock can be present in 5% of the patients, the 90-day mortality is more than 50%. So this is also statistics that is important to recognize, that any pulmonary embolism with shock, it's fairly intuitive that mortality is higher, it's more than 50%. So these are some of the statistics that you can remember. What about ARDS? So this is a slide I want you to pay little attention. So these are the studies that have come from France. So RV dysfunction in severe ARDS is present up to 56%. So this is possibly not as much recognized by intensivists, possibly including me, that we were not paying too much attention as to RV dysfunction that sets in severe ARDS, and it's up to 56% of severe ARDS can have RV dysfunction. So after this talk, possibly there should be a conviction that we need to assess RV more closely, especially in severe ARDS, who we are proning, to see how much RV dysfunction and measures to optimize that has to be done to improve their outcome. And when they have RV dysfunction, the studies have shown there is increase in 28-day mortality. And why does this RV dysfunction happens? Because there is hypoxemia and hypercapnia related, the pulmonary vasoconstriction that happens. And in ARDS, it is very clearly shown there is a lot of microthrombi formation that is seen in the pulmonary vasculature, and there is increase in the alveolar dead space that happens. So hypoxemic vasoconstriction or hypercapnia, which both happens in ARDS, causes pulmonary vasoconstriction, increases the pulmonary vascular resistance, and that leads to chronic increase in the pulmonary vascular resistance, leads to RV dysfunction, and increase in the alveolar disk space and this microthrombi formation. All this together leads to increase in the pulmonary artery pressure. And there are defined predictors as to which are the patients which develop RV dysfunction. So ARDS, severe ARDS with PaO2, FiO2 less than 150 definitely is one of the risk factors. So any severe ARDS, the message to an intensivist is we should keep assessing RV function at some intervals to see if RV dysfunction is setting in, because we don't address that, then we would possibly prolong the sort of a weaning from ventilation or prolong the hypoxemia or organ dysfunction, so on and so forth. Or PaCO2 more than 48. And very often in ARDS, we see CO2s, high CO2. So chronically high CO2s in ARDS, although permissive hypercapnia may be acceptable in initial stages, chronic hypercapnia for a long period of time is shown to be a predictor of RV dysfunction. Or if you have a patient with driving, now we have a good understanding of driving pressure, which is plateau pressure divided by P minus P. So if driving pressure is more than or equal to 18 centimeter of water, we know we have to maintain it at much lesser level, less than 15. So if it is more than 18 for a long time, this is a predictor of RV dysfunction. So if any of the patient has more than or equal to 2, the studies have shown RV dysfunction is present in more than 20%. Very simple to remember. So driving pressure is, anyway, we do it routinely. It is plateau pressure minus P, and CO2s, try to keep it low. So if any of these two, please keep in mind that RV dysfunction is something that may be present. So this is about ARDS. So at the end of my talk, pay attention that ARDS is a problem that we deal with, especially where they, we may overlook on RV dysfunction. So now let's talk about right ventricular myocardial infarction. Any patient with right ventricular myocardial infarction, RV dysfunction again can be present up to 50% of the cases. And if there is a reduction in blood pressure with cardiac output, can be present. So basically, RVMI presenting with shock can be present in 10%. And why does RVMI happen? The main culprit vessels is the right coronary artery, as you see. And there can be myocardial necrosis, which are shown to cause significant proximal RC occlusion. So that is something that has been shown. And the another important thing is right ventricle is usually has a better ability to cope with an insult. The reason is because of reduced oxygen demand of the RV when compared to the LV. So basically RV has a better ability to cope with an insult than the LV is what has been established because of its lower oxygen demand, and it has a dual coronary artery supply. And there is a more homogeneous transmural perfusion pressure in the right ventricle. So RV can sustain the insult better than the LV is what has been established because of the reasons it has dual coronary supply, and then it has a lower oxygen demand, and it has more homogeneous transmural perfusion. So this is something which one needs to bear in mind. Despite that, the RV can take an insult, especially when the MI has been larger, or if we are not optimizing the preload, afterload contractility, and so on and so forth. So now we'll come to the fourth element, which is post-operative cardiac status. Any patients who's undergone cardiac surgery, RV failure can happen in 0.1%. In post-heart transplant patients, RV failure can happen in 2 to 3%. In left ventricular assist device patients, RV dysfunction failure can happen in 10 to 20% of the patients. So any post-operative cardiac surgery who becomes hemodynamically unstable, half of the patients possibly will have RV dysfunction. And most of the cardiac surgeons would agree, and cardiologists, that RV dysfunction can be challenging in post-operative cardiac status when it sets in. So that is something one needs to understand. What are the reasons for post-operative? So prolonged surgical time is one of the reasons. Possibly it leads to myocardial stunning. And there is occlusion. Any occlusion of the grafts can lead to RV dysfunction, or reperfusion injury leading to pulmonary hypertension, or protamine-induced pulmonary hypertension. And this is something I want to emphasize. Any post-cardiac surgery or even ICU patients, when there is atrial arrhythmias like SVT or atrial fibrillation, 40% of the RV failing is due to the right atrial contraction. So when there is atrial tachycardia or atrial arrhythmias, that can significantly impact the RV dysfunction or RV failure. So, and in post-operative cardiac status, this can be a common occurrence, which we need to treat in a very aggressive way so that cardiac output is not compromised. Or some patient who has already pre-existing pulmonary artery hypertension or RV dysfunction, there this can get accentuated in the post-operative setting. So this is something epidemiologically it is shown. So now we'll quickly move to the clinical presentation and diagnosis of RV dysfunction, RV failure. So clinical signs and symptomologies are very variable. In ICU, I'm sure all of you agree, it does not have too much of relevance, clinical presentation. So as a low sensitivity and specificity, even ECG has shown to have a sort of a low sensitivity and specificity to pick up RV dysfunction. So, but any of the ICU patients where you have RV dysfunction, there is an acute deterioration. So suspicion has to be raised. Suppose in ARDS, if there is an acute deterioration with hemodynamic instability, please keep in mind RV dysfunction may be setting in. So there should be a high index of suspicion wherever there is acute deterioration in the setting of underlying RV dysfunction or indicators suggesting there can be a possible RV dysfunction. Echo remains the gold standard. So RV is a 3D structure. So there is a debate whether transesophageal echo is better or transthoracic. But 99% of the times, transthoracic echo is good enough to assess RV dysfunction. So transthoracic echo can determine RV dysfunction and has an ability to pick up cardiogenic shock. You need transesophageal echo mainly for determining the severity of acute pulmonary and for patent foramen availability. Because if there is a PFO and your PA pressures are high, then there can be right to left shunting, which I showed in the pictorial format. For that, you may need TEE. And TAPC is a very quick and easy way to determine because there is a separate video, as I said, where I have spoken only about RV function assessment. So this is not a video where I will dwell. Very quickly, I'm showing TAPC where you put the cursor on the lateral annulus of the tricuspid valve. If it is less than 12 millimeter, then you know there is RV failure. 12 to 18 millimeter, there is RV, some amount of RV dysfunction. More than 18 is considered normal. So echo is used to determine RV structure and RV function. In RV structure, it is suggested that linear measurements and the whole RV area measurement has to be considered to determine RV function. And for RV function, longitudinal systolic function and afterload has to be ascertained. So these are some of the indices that one needs to do in echo. And PA catheter is a good way to determine RV failure and RV dysfunction. Now this is obsolete, at least in our ICU, but CTVS post-cardiac surgery setting, very often PA catheters are put in place. Please make use of it. So if PA pressure, if one patient on PA catheter, if CVP is showing more than 20 millimeter mercury, raise your index of suspicion that possibly RV dysfunction is setting in. So it's a very good tool. PA catheters give you a lot of information to establish the presence of RV dysfunction. CVP more than 20, or this is very important, CVP more than pulmonary artery wedge pressure is a clear indicator that RV dysfunction may be setting in. So we had one cardiac transplant patient where severe RV dysfunction was there, and CVP was the only tool that was very valuable in guiding our fluid management, because this is, as I said, this is one setting, RV failure or RV dysfunction, where CVP can be relied upon to guide your volume status, because the dynamic indices of SVB, PVB are not reliable. So this is a point that I want to drive home to the intensivists. Or PA catheter where cardiac index less than 2 liters or stroke volume index less than 30 ml per meter squared or mixed venous oxygen saturation less than 55 millimeter. All these are some of the clues or indicators that RV dysfunction may be setting in. But please bear, there is a caveat. If PP is more than 10 centimeter of water, then pulmonary artery wedge pressure can be more than left ventricular end diastolic pressure. That is something one needs to keep in mind. So that's about the diagnostic. So the quintessence of diagnostic modality will be the echo. Echo for intensivists would be very valuable to look at the structure. And I tell very often, once you look into the 4-chamber view, if RV size is coming near to LV, you know for sure you don't need to do a linear sort of a measurement. More than 18 millimeter, you say RV is dilated. But if RV size is coming even close to LV, you know there is a definitive dilatation of the RV. So that's the easiest way. And RV function, you can use TAPC. These two are very valuable in echo. In post-operative cardiac surgery, if a PA catheter is present, you make use of it. If there is a CVC line sitting in for your infusion, many of the sick patient would have, just transfuse it and check the CP. If it is more than 18 millimeter for no diamond reason, then you know there may be RV dysfunction that may be setting in. So treatment can be divided into 3 broad categories. One is general measures, and the whole emphasis should be on general measures for an intensivist. Then there is this obviously inotropes, vasopressors, and inodilators, which we have to have some understanding. And then mechanical support, which is balloon pump, ECMO, so on and so forth. So we'll focus more on general measures. So the first general measure is to have high index of suspicion, screen the patients, because unless you screen with echo, look at the TAPC, look at the RV size, you wouldn't be able to ascertain whether RV dysfunction is setting in, which means to say a patient who's come with normal heart, when they're not doing well in ICU, keep assessing the echo because the initial echo may be normal in ARDS. But subsequently, if they're not doing well, keep repeating the echo because that may show that RV dysfunction may be setting in. This is an important lesson for intensivists that in ARDS, when you're proning, the initial echo may be normal, but we have to possibly keep doing serial echoes to determine RV dysfunction and treat the underlying cause. That is also very important. And volume, one needs to understand that hypovolemia is bad and even hyperolemia is bad. So both of them can lead to reduction in the cardiac output. And when there is hyperolemia, initiate on diuretics, loop diuretics or thiazides or in combination can be used. It is advised that loop diuretics or infusion is preferable as opposed to the bolus doses. And many a times renal replacement therapy has to be resorted to maintain volume status. As I said, we had a heart transplant with a RV failure and where we were aggressively dialyzing and we had to do CRRT to remove the excess fluid many a times because the fluid overload can be very challenging to manage in RV failure. So this is the general measures which we will talk in detail a little more. And this is a slide I want my trainees to focus. So the dynamic indices of volume responsiveness, which we very much rely on in ICU, like variation in SVB, variation in PPV or IVC distensibility index, IVC variability index, IVC collapse, all this becomes erroneous in setting of RV dysfunction. That is something I want you to understand because although it may show non-responsive, because when I was giving this talk, we had a pregnant lady with RV dysfunction who was on a ventilator. Her PPV used to show as 14 and 15, and it will easily tell us that she's volume responsive. IVC was dilated. We cannot, and there was an RV failure. So we cannot keep giving fluid in these because it can lead to further deterioration in these patients. So that is something I want you to clearly understand. Don't rely on SVB, PVB, IVC in RV failure. Maybe CVP may be a better tool. If CVP is showing very high, possibly you should avoid giving unnecessary fluids. But this rule does not apply in RVMI because in right ventricular myocardial infarction, they'll have normal pulmonary vascular resistance. Here, you could be little more liberal with fluids. And even here, the suggestion is only mini fluid allocals, 100 ml over 1 minute. You could see to determine whether there is increase in the cardiac output. You can use advanced cardiac output monitors to determine whether there is change in cardiac output with regards to after you are given fluid allocals. But what you can rely on is you can look at LVOT VTI change following a mini fluid bolus as one of the tool in RV failure, but definitely not SVB and PPV is something that I wanted to emphasize. And again, to re-emphasize, there is increase in the afterload in the RV failure, and this afterload further increases in mechanical ventilated, leads to tricuspid regurgitation and RV dilatation, which leads to underfilling of the LV, which leads to hypoperfusion and MODS. So this is something you need to understand is the vicious conundrum that happens. So there is increase in the afterload in already mechanical ventilated. You give more fluid depending on SVB and PVB, you'll further increase afterload, further compromise your LV filling pressure, further worsens hypoperfusion. And this is something one needs to be sensitive to when you are volume resuscitating this RV, because that is something I want people to clearly understand. And this becomes very important for an intensivist. And what about in patients with ARDS, in someone who is mechanically ventilated? As I said, in mechanically ventilated, there is reduction in preload, increase in the afterload happens, which becomes a critical issue. In ARDS, the tools we have is mainly these are the tools: control of hypoxemia, controlling hypercapnia, and controlling airway pressure and driving pressure. This is the tool to reduce the RV strain. And what are the numbers or what are the goals that we have in mind? Maintain plateau pressure less than 27, maintain driving pressure less than 18, 48, more than 48. It is shown that RV strain starts increasing, but at least try to maintain CO2 less than 60. I know it is very hard, but this is something to be attempted, and try to avoid worsening of acidosis. So these are the only tools we have in ARDS to prevent the RV dysfunction or RV strain. And this is a very important point I wish to make. In fact, the suggestion from the studies is showing that RV dysfunction possibly should be an indicator to prone the patients. It's not only hypoxemia. I know hypoxemia, we are very clear. PaO2 to less than 150, we start proning. But if there is RV dysfunction, it is suggested that proning is something that should be encouraged, because by proning, there is reduction in the afterload. It unloads the RV, and that also has a favorable effect on weaning. So this is something important, that RV dysfunction also should be one of the criteria that should be a part of your proning protocol, because it does reduce your afterload or reduces or unloads the RV. So this is something every intensivist should bear in mind. And this is another important point I wish to. So we had this pregnant lady who had a heart rate of around 140 with an SVT. So as I said, atrial arrhythmia should be avoided and tachycardia should be avoided, because your atrial contraction leads to 40% of the RV filling. And if there is atrial tachycardia, this filling is compromised, because RV depends on filling, RV filling pressure. It has to be normal. So low preload reduces the cardiac output, and more preload also, more volume also reduces the cardiac output. So optimal volume. So optimal volume can be managed by maintaining normal heart rate and avoiding tachycardia. So maintaining AV synchrony also becomes very important to optimize your RV dysfunction or RV cardiac output. So this is something which I want intensive care training to bear in mind, because our pregnant lady patient, where she came with 140, once we slowed down the rate, and then once we optimized, we reduced the afterload and reduced the sort of a preload, then her hemodynamic indices also very remarkably improved. So this is very simple things, but very important things intensivists can do: reduce the heart rate, optimize preload, optimize afterload, and enhance the cardiac contractility. Goes a long way in improving the outcome. So once you have, those are all the general measures. So the pharmacological treatment, then obviously you have to play with vasopressors. So any drug that you use should be able to increase your systolic arterial pressure, should be able to improve the RV contractility, and this drug should not increase the pulmonary vascular resistance. So this is very important. And systolic arterial pressure, our aim is to keep it more than pulmonary artery pressure if pulmonary artery pressures are high. So pay little attention to the choice of vasopressors. So in a very summarily, I can say the choice of vasopressor, the first choice is norepinephrine. The reason is it has some effect on improving the cardiac index, because it increases the systolic arterial pressure. As you see, systemic vascular resistance improves, your arterial pressure improves, and there is not much increase in the heart rate. And pulmonary vascular resistance is usually, it does not have any effect on the pulmonary vascular resistance. Yeah, and if we have to add a second drug, then vasopressin is the second drug of choice, again because it increases the systolic arterial pressure, systemic vascular, and it has no effect on the pulmonary vascular resistance. Dopamine is to be avoided because it causes atrial arrhythmias or tachyarrhythmias, and you don't want that. So once you have initiated vasopressors, then you may need to enhance the cardiac contractility. I think here I need to emphasize there is a myth. Some of the learned professionals also say don't use dobutamine, but it is very strongly recommended. RV dysfunction, dobutamine has to be considered in RV failure, but at a dose that it is acceptable. And up to 5 micrograms per kg is shown to be safe. And this is the only tool that we have to improve the cardiac contractility. But what is to be avoided is to increase the dobutamine to more than 10 micrograms, because your pulmonary vascular resistance starts increasing beyond the dosage of 10 micrograms per kg per minute, because this is the only drug we have. I mean, the other drugs also, which improves the cardiac index. At less than 5 micrograms, it has no effect on increasing the pulmonary vascular resistance. And at that dose, the effect on tachycardia also is on less. But more than 10 micrograms per kg per minute is what you can desist. Because that has shown to increase the heart rate, increase the pulmonary vascular resistance. Because in our pregnant lady, so, there was a sort of a suggestion by our cardiology colleagues that don't use dobutamine, but we continued using by controlling the heart rate at a dose of 5 micrograms per kg. And that is the good tool, because she was hypoperfused. And when we started dobutamine, her whole perfusion improved, lactate started coming down. And this is the tool we have to use in patients where we have a challenge with RV failure. And milrinone is something also which has a phosphodiesterase inhibitor, which could be considered if so this all depends on the center which is comfortable. And levosimendan is a calcium channel sensitizer. All these are agents which I'm sure all intensivists know that improves the cardiac index, and all these have some bearing on heart rate also. But Dobutamine, which is a cheaper drug, more commonly used, easily available, used at this dose, and we had a dramatic result. We had a pregnant lady who came with double dose vasopressors from another tertiary hospital. Now we weaned her off and she needed dialysis. Now we have extubated her. She's absolutely stable and we are sending her to ward as I'm giving this talk. So this was a patient who had an intrauterine death, who came with RV failure. So patient was immediately managed with expelling of the fetus. And then all the measures that I'm talking was applied in this patient. We controlled the heart rate, we reduced the preload, and we improved the contractility by giving dobutamine. Obviously, we had to do good organ support, but the whole tenets of management where we could make a difference is having a sound understanding of how we manage the RV failure really saved the life of this patient. And dobutamine is something where we had a discordance with our other colleagues, but we continued and she did remarkably well. So this is something I want to drive home to our intensive care colleague. But if all these are failing, you can use nitric oxide. We used at a dose of 5 to 40 parts per million. And we have used this in our cardiac transplant patients where we have refractory RV failure. And this is easily available in India. You could use this nitric oxide in refractory. So this is something one could even consider in ARDS where RV dysfunction is set in. One could even think of nitric oxide as one of the adjuncts. So once all this has failed, then obviously you have to resort to mechanical support. So if there is a cardiopulmonary failure, when I say cardiopulmonary, where there is ARDS with RV dysfunction, you have used nitric oxide, you have done all those good sort of a management, things are not improving, then you can think of if there is respiratory and RV failure, and RALA ECMO is what is suggested. If there is biventricular failure, VA ECMO is what is suggested, obviously because you want to support the heart and the lungs. If it is only right ventricular failure, then you have other devices like percutaneous right ventricular assist device, which is Impella or Tandem Heart. And there are surgical RV assist devices like Centrimag and Biomedicus. And if there's isolated respiratory failure, which many intensivists now love to talk about, is the VV ECMO. But I think the point of caution that I need to make again here is try to optimize maximally medically, because even our patient, as I said, intrauterine death with the RV failure with double vasopressors. She was on noradrenaline, double digit, and vasopressin. But with a good sound understanding of optimizing preload, optimizing afterload, enhancing the myocardial contractility, good organ support, she remarkably improved. And as soon as she started showing some oxygenation improvement, we brought down the PEEP very quickly. The reason is because the more PEEP produces more afterload increase to the RV. So all this effective medical management, and even you can go up to nitric oxide. Don't undermine the role of nitric oxide. If all this is failed, obviously think of ECMO. But again, in severe ARDS, if there is RV dysfunction, you are only doing VV ECMO and not addressing RV failure, possibly your weaning becomes more difficult. So again, a point of suggestion that pay attention to RV, optimize RV even while they're on VV ECMO, because unless that is sorted out, possibly their weaning becomes difficult. So this is something I want every intensivist to bear in mind. In your zeal and enthusiasm for VV ECMO, think of RV also, because unless you're addressing that, things may not get better is what one needs to keep in mind. And this is a pictorial representation of how Impella looks, your RV assist device, and this is the Centrimax surgically. So now just a last slide on targeted management, just a brief summary of all the talk that I've given. If there is right ventricular myocardial infarction, the mechanism that impairs the cardiac output is reduced in the RV contractility. Here, the main tenet of treatment would be treat underlying cause, which is percutaneous intervention thrombolysis, which cardiologists are very good at. If it is pulmonary thromboembolism, the mechanism which reduces cardiac output is an increase in the RV afterload. Here, the treatment, if there is hemodynamically stable, is systemic anticoagulation. If there is hemodynamically unstable, then obviously you have to think of thrombolysis, or catheter-related thrombolysis is something you have to think. If there is a decompensated pulmonary artery hypertension, which we very often see in ICU, with the patients coming with PA pressures of 70, 80, the mechanism of cardiac output drop is due to increased afterload. Here you can optimize preload, afterload, optimize your contractility, all that, and think of inhaled nitric oxide also as an adjunct. And that is something we should possibly do more often. In ARDS, again, the mechanism is increase in the RV afterload. And the only tools that we have is protective lung ventilation. Avoid hypoxemia, avoid hypercapnia, avoid acidosis, and keep the driving pressures low. All these are the only tools that we have in ARDS. And think of nitric oxide. Always VV ECMO is there, but pay attention on RV function also. So all this I said. And in post-operative cardiac status, the mechanism is mainly volume overload or posterior. They can have a non-STEMI or STEMI, and arrhythmias is shown to be more commoner in post-operative cardiac status, which leads to RV dysfunction. Again, you have to use diuretics, vasopressors, and antiarrhythmic drugs to control the rate. So this is summarily the mechanisms and the primordial sort of a treatment that you should be guided by is what the slide tells you. So conclusions, my friends, RV dysfunction is a very important topic and may not be a very easy topic because there are review articles which I have had a review article which I went through which was around 30 pages. So it is a complicated topic, but you need to simplify it and try to understand the salient key nets. That's what hopefully I have tried to do it. So acute RV dysfunction and RV failure increases the frequency of admission to ICU, and it is increasingly recognized in ICU. And the problem is it can aggravate other critical diseases. If someone has a septic shock can be worsened if there is a concomitant RV dysfunction is present, or respiratory failure can be worsened, so on and so forth. And any patient, you need to assess RV dysfunction. Always you need to adhere to the principles of echo assessment of RV dysfunction with hemodynamic monitoring and possibly with advanced cardiac output monitoring to have a good understanding of the cardiac indices and tweak your management and assessing the prognosis. And early diagnosis of right ventricular dysfunction is important to determine and to understand the etiology specific treatment. And the main principles of etiology is improve RV function, improve the cardiac contractility, optimize preload, and reduce the RV afterload. And there is a lot of research happening on understanding the molecular mechanisms of myocardial injury. And I think we need more therapeutic tools, how we can salvage the myocardium, which has become dysfunctional, whether there are any drugs that could be thought of to revitalize the dysfunctional myocardium is where the research is happening. So this is in essence that you can keep in mind. So thank you one and all. So you can visit my website www.drpradeeprangappa.com to rehear. And I request all the trainees to please listen to this lecture 2-3 times and keep those pictures in mind. I think that will make your understanding, because you need to have an absolute understanding of RV to do effective management in ICU of these patients and save more lives. So I end with this beautiful quote of the 4 cardinal values or virtues: wisdom, justice, courage, and moderation. So I would add compassion along with courage. So thank you, Varendra.